program, I'm sorry, the program says
I
others.
was supposed to be the first speaker, but he was so excited about that paper that he wanted to be first. So, but wait a minute, before you take his last slide down, I want to say in advance, I agree with the last bullet. The question is not if to screen, but how and who. So now you can put my slides up. Thank you. So anyway, while that's happening, thank you very much for inviting me. I was really very honored to be invited to come here, and I thought it would be very pleasant to be here, except I didn't realize that you timed it so that your paper would be out today, and I would have to apologize more than I expected for PLCO. So, I think everyone's familiar with PLCO. We recruited our patients from, which is the laser? The green one. Our patients from 1993 to 2001 from 10 different centers in the United States. And with respect to prostate cancer, we performed annual screening with a rectal exam for 4 years and a PSA test for 6 years. And PLCO is much different than, I think, any of the ERSPC sites. And the reason is that all patients were consented and then randomized. And if they were randomized to the intervention arm, the screening results were reported back to the patient and to his primary care physician. They were not reported back to his urologist. And all of the decisions about how to handle an abnormal screening test were left to the prevailing community standard of care. So that is potentially what explains the biopsies and potentially what explains some of the treatment decisions. And of course, the same thing was happening in the comparison arm. There was no mandated biopsy. We were just reporting a PSA number and a digital rectal exam result to the patient and to his doctor, and they made of that result whatever they wanted. And you can see our main endpoints, of course, is cause-specific mortality. Jonas already showed you this slide now with between 10 and 13 years of follow-up. Absolutely no difference in the overall mortality. And I had highlighted a statement from the abstract. And our conclusion from PLCO is that organized annual screening, the way we did it, is not better than opportunistic screening. We are not saying that screening is not better than observation. And I had attempted to highlight that, but for some reason, it's not showing today. And I think there are a few things that we all have to be honest about with respect to PLCO that may make the results in PLCO a little confusing to interpret, and maybe that's why they're a little bit different from the ERSPC. And the main things I want to touch on are these 6 points here, and we'll start with pre-screening. This is from our New England Journal paper in 2009, and you can see that 4% of the patients had previously been biopsied, and that close to 40 and 50% of the patients had had one or more PSA tests and or digital rectal exams in the years leading up to randomization. So this was a very heavily pre-screened population. On top of that, we suffered a little bit from compliance in the screened arm. Only 85% of the patients underwent one or more of the recommended screening tests. And by the same token, there was substantial contamination in the control arm, or what we had started calling the usual care arm. 40% of the patients within the first year, and more than half of them by the 6th year of screening, and you can see the rates of the digital rectal exam. And so when you sort of stand back from this, we're not comparing screening to no screening. We had about half the screening intensity in the usual care arm as we had in the screened arm. And that's why our conclusions are that additional screening over this prevailing opportunistic rate of screening doesn't provide any additional mortality benefit. And I should say that the usual care arm of the PLCO trial did not receive usual care, even by US standards. So the usual care arm had 22% more cancers than a matched group of contemporary men in the United States. So even though they were randomized to not be screened, they nonetheless sought more aggressive screening than the average man in the United States did. And if you compare the usual care arm to men in the pre-PSA era, they were 2.1 times as likely to be diagnosed with prostate cancer. Now, in the screened arm, there was obviously additional prostate cancer, but you can see there were 2 times as many cancer cases in the screened arm as the pre-PSA era, 1.6 times as many as the average contemporary man in the United States, and 1.2 times the amount of cancer in the control arm. Biopsy rates. Jonas showed a slide, and this comes from this paper we published in 2008, and this is the number that many people quote, that only 40% of the patients with a PSA of greater than 4 had a biopsy. That was within the first year of identifying that the PSA was elevated. And the points I would make are that the magnitude of elevation was important because when some doctors in the community saw that the man's PSA was only 4.1, the first thing they did was repeat the PSA, and for some patients, it normalized. And that's why for men who have very mild PSA elevations had very low biopsy rates, but men who had higher PSAs, say over 10 or between 4 and 10, had much higher chances of getting a biopsy during the first year after the elevated PSA was identified. And we did spend a fair amount of time trying to analyze whether the behavior of community doctors was appropriate, and the hazard rates for a biopsy looked pretty good. If the patient was relatively young or he had a family history of prostate cancer, he was more likely to get a biopsy. He was less likely to get a biopsy if he had symptoms related to BPH, if he had had a prior biopsy, and if he had had prior PSA testing. So it looked like, although the biopsy rates were low, they were at least reasonably low, and we could explain them on the basis of some of these other conditions. And the other thing I would say is that in delaying the biopsy, it doesn't appear that the patients were hurt. Because if a patient had an elevated PSA, as I told you, the main reaction in the community was to repeat the PSA. If the repeated PSA was less than 4, but that patient ultimately developed a PSA of greater than 4 again, and he then underwent a biopsy of the prostate, he had only 10% of the time was it positive for cancer, and 22% of the cancers were Gleason 7 or above. And this rate of a positive cancer diagnosis is substantially lower than the man who had a repeat PSA. It remained elevated. For that man, he had about a 40% chance of having cancer, and about a third of the cases had an aggressive histology. So I don't think that delaying the biopsy was harmful to these patients. The other way of putting this into perspective is to look at the overall biopsy rate on a 4-year basis, because we now need to compare ourselves to the gold standard in the ERSPC, which is mostly every 4-year screening. So this is from the 2009 publication. About 85% of the patients who had an elevated PSA had a biopsy within 4 years. In PLCO, 69% of the patients with an elevated PSA had a biopsy within 4 years. But if you consider repeating the PSA and it being less than 4 on repeat, then we could account for 85% of the men who initially had an elevated PSA. So I think the results in those respects are very comparable. And the other thing I would point out is that even though we didn't biopsy a lot of men in PLCO, the biopsy detection rate was at least as high, or in some respects even higher, than the cancer detection rate in the ERSPC. And this, let me remind you, is in a population that was heavily pre-screened, right? So despite a lot of pre-screening, despite the fact that we don't biopsy as many men as get biopsied in ERSPC, the rate ratio of prostate cancer detection is at least as high and maybe even higher. So I don't think it's a real fair criticism to point to the biopsy rates in PLCO as a major problem. And as Jonas said, the other thing about PLCO is that the mortality rates in both arms are lower than the mortality rate in either arm. And again, these, I have to apologize, are the 9-year ERSPC core group rates. Another point that's really worth considering is the overall survival of the men who enrolled in the PLCO cohort. And this is a study which is tainted by what's called the healthy volunteer effect. And so here is the standardized mortality ratios for any cause of death in PLCO, and you can see it was only 46% of what was expected. And you can see the different types of things that patients could die of. Patients in PLCO were very healthy. By another measure, they were less likely to develop these cancers than you would have otherwise expected. They're just healthy people who probably engage in healthy behaviors. And even if they were diagnosed with one of these other cancers, their observed survival was generally a little bit better than you would have expected. So these are patients who behave in a healthy way, and they probably seek aggressive treatment once they develop a problem. And this, overall 46%, expected mortality rate, even after you adjust it for the fact that the population didn't have as many smokers, education, marital status, you can see the adjusting factors. Even when you put all of those factors in here, the adjusted standardized mortality was only 63% of what you would have expected. This was a very healthy group of men who just didn't die as rapidly as we want. How about prostate cancer treatment? I noticed in Tony Miller's editorial, he still is harping on this difference in treatment in ERSPC, whether it's the type of treatment or whether it's the venue of the treatment in an academic center versus a community center. Well, I'm happy to say there's one really good thing about PLCO. We have absolutely none of that. So treatments are, for the most part, done completely in the community, and they're very, very similar. I had previously showed the major, clinical stage 2s, but overall you can see the rates of radical prostatectomy were very similar. And this is the United States, and so no known curative treatment is only in about 10% of the patients. Most men get aggressively treated. Now, what about the observed over the expected prostate cancer mortality in PLCO? This, just like everything else in this population, overall the hazard ratio for prostate cancer death was about half what we would have expected it to be at the beginning of the study. And you can see it was a little better in the intervention arm than in the control arm. This, I realize, is a very busy slide. And in this analysis, we tried to adjust for the fact that men in the intervention or in either of the arms had a number of PSA tests either prior to or during the study. And you can see that on a univariate analysis, the number of PSA tests you had was significant in reducing your prostate cancer mortality. And that was true for both arms combined and even for the intervention arm. But when you adjust for all the factors that can account for prostate cancer mortality, that goes away. However, there's one group where it really doesn't go away, and that's men who were randomized to the intervention arm and who never got screened. Remember, there were 15% of the patients who never got screened in the screened arm. And you can see among that particular group of men, the hazard rate was almost fourfold for prostate cancer mortality. And when you adjust it for the factors that are also known to be associated with prostate cancer mortality, it's still significant. And that's why I keep getting back. PLCO is not saying there's no benefit to screening. It's saying there's no benefit to organized aggressive screening over the opportunistic screening that occurred in the control. Finally, we've confused everybody on comorbidity, and I really hate talking about this when Peter Albertson is in the room. So you can maybe explain this better than I can. But this is from the most recent JNCI publication. When you look at the modified Charlson score, cancer comorbidity had no effect on, overall morbidity had no effect on prostate cancer death in either arm. This is different from a post hoc study that we presented about a year or so ago when we looked at men who had really no or very minimal comorbidity. And notice here that it pertained to only about 30% of the men in the PLCO trial could be considered by the absolute strictest definition of having no comorbidity. And in that, restricted definition of no comorbidity, there was a statistically significant benefit for screening the way we do it in PLCO versus the control arm. Absolutely no benefit for men who had one or more comorbidities. Now, if we continue with that expanded definition of comorbidity, these were the data that we used in that JCO paper I just showed you. So if you had no comorbidity, your hazard rate for prostate cancer death was 0.56. If you had any comorbidity, it was 1.43. When we now relook at the data 3 years later, the hazard rate has risen in the no comorbidity and fallen a little bit, although it is still statistically significant for that definition of comorbidity, which is a very strict definition. If you had hypertension that was controlled with medications, in that definition, you're considered to have a comorbidity. So in summary, I would just reiterate what we're saying. PLCO shows no benefit of organized over opportunistic screening. And all of the data from PLCO have to be considered with a little asterisk, because it turns out that unwittingly we studied a relatively healthy population. And by the way, we only have about 150 men in each arm who have died of prostate cancer. And we're still waiting for about 80 to 85% of the population in PLCO to die. So there's a lot more time, and we'll have further follow-up on this down the road. Thanks very much for your attention.
So
Questions?
Oh, go ahead.
Questions for Dr. Andriole?
Oh.
Jonas.
Yeah, I have one. I have problems with this to say that opportunistic screening is as good as a screening program. Because when we look, for example, in Sweden, we know that we have had opportunistic screening. It started when we started our screening study. But this opportunistic screening in Sweden has doubled the incidence of prostate cancer, but so far not have led to any decrease in prostate cancer mortality in Sweden.
But it's probably not opportunistic enough. So that's why we say we don't know how to screen. So you remember, the control arm of PLCO had half the screening intensity of the intervention arm. Half the screening intensity of annual screening is screening every other year. And there are studies in ERSPC that show that that's a real good way to screen. Yeah, so that's why I'm thinking the control arm of PLCO is a lot like the screened arm of ERSPC when you factor in the proportion of men who are getting PSA tests.
Because what I am afraid about the opportunistic screening, how it goes on in Europe, or at least in Scandinavia, is that it leads to a lot of overdiagnosis, but not to any decreased mortality. And then we have all the harms but no benefits.
I mean, it's probably a very bad word to say opportunistic. I mean, I don't know what the best word is, and that's why I say we need to define what constitutes a minimally effective form of screening, and it's probably some manifestation of what's done on average in ERSPC. And then, in our next study, see if additional screening beyond that makes a difference. You see what I'm saying?
Other questions from the audience? Not, Jerry, you did a brilliant job. And
Okay.